So the next speaker is me, and I'm going to concentrate on actually the majority of our patients, PS2 in the elderly, if we can have the slides up. So we call these special populations, but in fact, if we run the numbers and are clear-eyed about it, those over 70 are more than half the patients we see, and PS2 are probably 30 to 40% of the total. So these are majorly neglected because, by and large, these folks don't show up on clinical trials. My disclosures: I've been accused of pharmaceutical promiscuity, and this is proof. The incidence of lung cancer in the U.S., these data are a little bit old, but they really haven't changed much. Our median age, pretty much across the board in North America, is over 70. And yet, when we look at clinical trials, these folks are underrepresented. So about 2/3 of our patients are 65 years of age or older. The likelihood of receiving treatment of any sort decreases with advancing age. These are data from Marty Edelman and David Doff, published 5 years ago in JCO, looking at the SEER Medicare database, and you can see that the majority of folks with advanced non-small cell who are over 65 or 70, in fact, do not receive chemotherapy. And amongst those who do get chemotherapy, the majority are getting single agents. And yet, even within the database, you see a clear-cut survival advantage for chemo, chemo over supportive care, and doublets over single agents. As I mentioned, clinical trial participation decreases with advancing age. The likelihood of receiving treatment decreases with advancing age. If we look at an analysis of SWOG trials, only fewer than 40% of patients in lung trials were over the age of 65, and an NCI series showed that 42% of those on lung trials were over 65. And if we go back to the percentages, 65 and older, about 2/3 of our patients. There are a number of reasons for this. There are unique issues in the elderly that obtain across the board, not just in lung cancer, but are probably more pronounced in advanced disease. We have physiologic compromise, including declines in hepatic, renal, and marrow function, cardiac risk, compromise to the immune system that makes folks more vulnerable to infection, comorbidities. We never shed comorbidities as we age. We just seem to accumulate them. And those of us who are past a certain age can probably attest to that fact. Polypharmacy, which complicates features with drug-drug interactions, increased risk of adverse reactions. As your performance status declines and your age advances, the effects of declining performance status are probably magnified. And we do see a high degree of frailty with people who are ostensibly good PS, but it doesn't take much to throw them over the brink. And I've just been emailed twice in the last 20 minutes about just such a patient who now is in the ICU with a creat of 7, having received pemetrexed. Impaired social, emotional, and financial resources are another issue that comes up. So, lack of consensus. What is the standard treatment in elderly? Evidence-based data until very recently. We really had very few elderly-specific phase 3 trials overall, and certainly very few assessing the role of platinum. I'll show you one game-changing trial in that regard. And for the most part, we've broadly extrapolated from age non-specific data. Do targeted agents pose a special challenge? How do we treat the group that's increasing in frequency the most, those over 80? And finally, which physiologic considerations do we consider, particularly when we're addressing relatively innocuous drugs such as pemetrexed, which may be a lot safer in certain groups. So here are the 4 single-agent phase 3 trials in elderly non-small cell. 3 of these came from Italy, from one section of Italy, the Neapolitan area, and one from Japan. You can see that several of these trials are fairly old. The game changer, at least in terms of treating the elderly, was the Elvis trial, Elderly Lung Vinorelbine Italian study, that showed a clear survival advantage for Vinorelbine versus best supportive care, with more than a doubling in 1-year survival rate. A study by a rival group in the Naples area looked at combination gem Vinorelbine, a non-platinum duo, versus Vinorelbine, and purported to show, again, a survival advantage for the combo. But note, Vinorelbine fared poorly. It didn't do any better than best supportive care in the Elvis trial. And finally, a much larger, much more credible trial, nearly 700 participants, comparing the single agents to the combination, showed absolutely no difference. And it's been Gradelli's conclusion, based on the bulk of work done by him and others, that single agent non-platinum therapy as the standard. And he still sticks to that, although we have more modern data that would question that. This is Japanese data looking at docetaxel. And remember, in a much larger age non-specific phase 3 trial, docetaxel in combination with platinum was better than Vinorelbine and cisplatin. So this is single agent docetaxel versus Vinorelbine at, I argue, user-friendly doses. In fact, in the elderly now, I'm increasingly using 60 per meter squared when I do use it. Global quality of life was similar, but symptom improvement was better with docetaxel. We see significant improvements in response rate and PFS, and a numerical improvement in median and one-year survival rates. In fact, a fairly stark improvement, but this study was woefully underpowered for survival advantage, and unfortunately the p-value was not significant. What about platinum? Well, most of our data are retrospective. There was a little cottage industry in the early part of the new millennia, spearheaded by myself, Rogerio Lillenbaum, Karen Kelly, and others, looking at various cooperative group phase 3 trials and trying to isolate outcome in the elderly. And the bottom line is there were no major differences in survival, trend for greater toxicity, no surprise, particularly myelosuppression, trend for improved tolerability, at least with carbo compared to cisplat. And the major limitation here is that the folks who make it on these trials, particularly elderly folks, are probably not representative of the population in general. And so can we really extrapolate these data for the special folks who go on to clinical trials to the broader population? This is ECOG 5592. It's the study that was responsible for paclitaxel's approval in the US, and basically comparing etoposide plat versus paclitaxel and platinum using now archaic 24-hour infusion. The bottom line, the elderly had more comorbidities, particularly cardiovascular and respiratory disease. They had more toxicity, particularly leukopenia and neuropsych toxicity. We didn't have separate categories for fatigue or lassitude, so a lot of that unfortunately got rolled into that category. But despite this, there was no difference in quality of life, treatment outcome index, response rate, time to progression, median 1 or 2 year survival. So if they made it on the trial despite more comorbidities and more toxicity, they did just as well. And I have concluded from that time onward that performance status really trumps age, at least in the context of clinical trials. The major trial that has changed the therapeutic landscape comes from France, where they're able to do these sorts of efforts. This was a broad trial, ages 70 to 90, PS 0 to 2, comparing single agent, take your pick, either Vinorelbine or gemcitabine, to an unusual to a combination of pac carbo, but given with an unusual schedule. This is carbo every 4 weeks with paclitaxel administered weekly, breast cancer type doses, 90 per meter squared, 3 weeks in a row with a week off, and then fairly standard doses of gem and Vinorelbine. And again, this trial did allow PS2 with the other usual eligibility criteria. If we look at the basic demographics, no surprise, vast majority were male. The median age here was 77. Contrast that to our standard clinical trials, where it's usually about 62. Over a quarter of patients were PS2, and you can see roughly a third had squamous histology, with about 20% never smokers. A lot more toxicity, as we'd imagine, for the PAC-carbo combination. More neutropenia, more febrile neutropenia, and other forms of myelosuppression, more neuropathy, more anorexia, and diarrhea in this group. But a higher response rate, threefold difference, 10.9% versus nearly 30%, highly significant. And we see a doubling in progression-free survival, 6 months versus 3, with lots of zeros in that p-value. At 1 year, the PFS in this group receiving combination PAC-carbo was 15% free from progression compared to only 2% with single agents. And this translated into a survival advantage. You see a 4-month improvement in median survival and nearly a 20% improvement in 1-year survival rates. Again, with lots of zeros in that p-value. Now, there are Japanese data that have not shown such a benefit. In fact, single-agent docetaxel, which you could argue is better than gemcitabine or Vinorelbine, did just as well as dose-attenuated docetaxel and platinum. But I would argue that the French population is probably a bit more similar to the US population. So really the first study that's entirely devoted to elderly patients showing a benefit for any platinum-based doublet, in this case carbo. Gradelli and others have made hay about the toxicity, but I would argue it's acceptable. And this was really led to changes in the both ASCO and NCCN guidelines showing that this is a reasonable option. What about other taxanes? Nab-paclitaxel has been looked at in this setting. Much faster infusions, no decadron use. So again, a weekly dose, 3 weeks out of 4 with carbo, very similar to the French study, versus a more standard Q3-week pack carbo. We know that there are higher response rates in squamous histology, albeit no significant differences in the overall intent to treat population for either PFS or overall survival. But in the elderly cohort, now granted this is a sub-analysis, but fairly large, 150 patients, we see a 9.5-month improvement in median survival. Serendipity or real? And if it is real, is it due to the formulation, the nanoparticle albumin-bound technology, or is it due to the schedule, which was weekly, as opposed to the more conventional and more toxic Q3-week paclitaxel? So here's overall survival for those under 70. The curves are superimposable. But for over 70, a clear distinction favoring the weekly NAB-PAC approach with a hazard ratio that's below 0.6, pretty impressive. More toxicity for PAC carbo, and the toxicity differences are exaggerated in the elderly, particularly when it comes to neutropenia and sensory neuropathy. Grade 3 and 4 sensory neuropathy at 23%, I'd argue, is unacceptable. Where are we going? This is an ongoing trial called the Bound 70, looking at the Szynski weekly without interruption schedule for NAB-PAC and carbo versus the IFCT approach with a 1-week break, so basically 3 weeks out of 4 with safety and tolerability as the primary endpoint. Targeted agents, there's a lot to talk about. I'm going to concentrate just on 3 topics: retrospective analysis of BR21, and then retrospective data for mutation positive, and finally bevacizumab. So this is BR21. If we look just at the elderly folks compared with young individuals, they had significantly more overall and grade 3 and higher toxicity, p-value of less than 0.001. They were more likely to stop treatment, but they still had a relative survival advantage. And again, this is an unselected individuals, 2nd and 3rd line, PS01 as well as 2 and 3. This difference is not significant, but it is at least numerically better. And so elderly patients treated with alatinib having similar survival and quality of life compared to younger patients. If we look at LUX-Lung-3, the trial of afatinib versus PEM-CIS that showed a response and PFS advantage compared to chemo, the benefits here are seen in both those under 65 as well as those over 65 with a hazard ratio of 0.64. And then finally, bevacizumab. Lots of controversy. This is a paper by Suresh Ramalingam, the chair of the Thoracic Committee at ECOG, that called into question whether it was worth treating those over 70 with bevacizumab. There was no improvement in survival, borderline improvement at best in PFS. Here are the survival data, and certainly more grade 3 and 4 toxicity, more neutropenia, more bleeding, more muscle weakness, more neuropathy. If you drill down further, and this is a subsequent paper published 3 years ago in lung cancer by Heather Wakely, it's only women over 60 who seem not to benefit. They do incredibly well in the control group. Those under 60 and men of any age retain a statistically significant survival benefit. And we've gone back and actually pooled the data from 4599, the trial that got bevacizumab approved, with the control arm of Point Break, which was PAC carbo bev. Now you can argue it's 2 different trials, 2 different periods. The eligibility, however, were essentially identical. It was the same regimens. And if you do look at the data, 75 may be the new 70. Over 75, you see no obvious progression for your overall survival advantage, either for the pooled groups or, for that matter, going back to 4599, just partitioning that out. So the data overall and the data for 4599 are about the same. So I will certainly use bevacizumab up to the age of 75 in appropriate patients. I do take pause, though, above 75. We see a lot more toxicity for the bev combination, particularly in those over 75. The grade 5 events are 8% compared to 2% with PAC carbo alone. And the rates of treatment discontinuation for AEs are also higher. So bottom line, Bev is not contraindication in the elderly. Joint analysis suggests that we could probably use this drug at least up to the age of 75, but you got to be careful. You got to factor in a lot of other issues, particularly comorbidities when you're making therapeutic decisions. What about the very old? Those over 80, 20% of lung cancer deaths in the US occur in patients over this age, and the number of lung cancer patients over 85 will quadruple by 2050. Now, certain cultures, those folks will be put on an ice floe, but in this society, I think we're still going to treat individuals, regardless of their age, really based on their fitness level and not on their chronologic age. We have virtual absence of any data in this group, so choosing appropriate therapy in this enlarging population is very challenging. We went back and looked at ECOG 1594, the four-arm trial that basically showed similar outcomes for platinum-based doublets. Fewer than 1% of individuals on that trial were over 80, and they did badly. PFS, median survival, about half that observed in the younger old, those between 70 and 80, and essentially no one was able to go beyond 4 cycles of treatment. If you go back to the French data, the IFCT data, and look at those over 80, they still had a survival benefit. In fact, the hazard ratio, which is a little bit hard to read here, was better in that group than those between the ages of 70 and 80. So using gentler non-cisplatin weekly taxane regimen still translated into survival benefit. And then there are major protoplasmic issues. Comorbidities can have a deleterious influence on survival. The normal physiologic changes that occur with aging will often restrict our therapeutic options. Renal function is key. Carbo is likely preferable to cisplatin in a significant percentage of these individuals. And remember, in the package insert, pemetrexed not to be given in creatinine clearances under 45. We all fudge this. Many of us will give it at 35 or 40, but if you're going to run into toxicity, it is typically in an elderly individual who has ostensibly a normal creatinine. This is despite vitamin supplementation. Myelosuppression is worth with aging, so strong consideration of growth factor support, weekly dosing of taxanes as opposed to the more toxic Q3-week dosing. And again, increasing fat mass and decreasing water content can change the pharmacokinetics of these drugs and really lead to much higher AUCs than you'd see in a younger population. So there is a major interaction between age, performance status, and comorbidity when we are looking at the elderly. So again, the median age is over 70. The elderly are more likely to be frail and or vulnerable. Their functional reserve is compromised. Whether or not to do a modified comprehensive geriatric assessment is under much debate. Probably some variation of this needs to be introduced to fine-tune our predictions of both vulnerability and prognosis. However, if they are fit, they do as well or nearly as well as younger patients, although the toxicities are worse. And we have good level 1 evidence-based data showing a clear benefit for non-platinum monotherapy versus best supportive care. No consistent superiority for non-platinum doublets. Retrospective analyses show a potential benefit for platinum combinations across the board, and at least one positive prospective phase 3 trial showing therapeutic superiority. A lot of issues go into our therapeutic decision-making, the toxicity profiles of the agent, PS, pharmacokinetics, comorbidities, baseline organ function, pay attention to that. Social support, probably one of the worst prognostic signs is when that new patient comes for their appointment and they come alone. That is an immediate phone call to social service. And I'd argue that those over 80 are probably a different group. Last 2 minutes, I'll talk about PS2, current state of the art. Again, this is a heterogeneous group. If we're honest, they're probably 30 to 40% of our population. They're almost always excluded from clinical trials. They tolerate treatment poorly, and they tend to have poorer survival. That's what we know. What we don't know is how to accurately assess PS2, the relative influence of comorbidity and disease burden on both performance status and treatment outcome, and really what the best therapeutic approach is in advanced disease. First off, there is significant discordance between the assessment of PS by physicians versus the patients. We tend to look at our charges with rose-colored glasses. Dave Stella sent a team of postdoc fellows to actually interview patients, and agreement between patients and physicians occurred in only 43%. We overestimated PS, actually assigning a better PS to our patients nearly 40% of the time. And the influence of PS on outcome is shown here. This is a rather old recursive partitioning analysis of ECOG trials. In addition to gender and appetite and by inference weight loss, PS is one of the most important factors in determining prognosis. If you're PS2 with diminished appetite, regardless of gender, your median survival is atrocious, 2 to 3 months. And yet, if we look at data from the UK, the benefits of chemo, even in this poor PS group, is just as good as those with good PS. In fact, it may even be more pronounced, particularly if it is due to, if the drop in performance status is due to the underlying cancer. So if you go back to that Elvis trial, the survival advantage was probably driven by the PS2 cohort. They had a tripling in median survival. If we look at the CLGB 973 effort, which I'll show you shortly, Carbo-PAC did better than PAC in this group. On the other hand, this platinum-based trial showed no benefit over Vinorelbine alone. This is 9730 that compared combination PAC-carbo to single-agent paclitaxel. And if you look at the solid group, the yellow and pink colors, which is the PS2 group, the combination doing much better than single-agent. Intriguingly, the good performance status group really having very little difference in outcome. There are a number of PS2-specific trials over the subsequent 10 years. 1599 was the first dedicated PS2-specific randomized phase 2 cooperative trial. Helen and I were involved in the Stellar 3 and 4 efforts, which were really the first PS2-specific randomized phase 3 trials. And then OSI at the time looked at erlotinib testing TKIs in PS2. This is 1599 looking at dose-attenuated PAC-carbo and GEM-CIS, omitting the day 15 dose. Again, pretty awful median survivals, but better than we had seen historically. No major differences between the two specific regimens. And one-year survival rates that I'd argue establish a benchmark of about 20%. So if you go from best supportive care to single agent, we see some increment, maybe some additional increment of about a month and a half to 2 months if we look at doublets. The Stellar 3 trial, this was an attempt to look at putatively less toxic taxane formulations, polyglutamated paclitaxel, combined with carbo versus standard PAC-carbo. Absolutely no difference in overall survival, with really no major differences in toxicity. And the same holds true for single-agent polyglutamated paclitaxel versus either GEM or Vinorelbine, with no difference in survival. So the notion that somehow a new formulation would be better fell by the wayside, although this study did, in multivariate analysis, establish important prognostic factors, including baseline albumin, the presence or absence of extrathoracic tumor, the number of comorbidities, and smoking history, all of which bore out poorly. What about erlotinib? There's been a perception that the TKIs are less toxic, so maybe we should give these preferentially compared to chemo. So this was a PS2-specific trial spearheaded by Rogerio Lellenbaum, and lo and behold, chemo does better in this unselected population. You see a 3-month difference favoring PAC-carbo compared to erlotinib. SWOG went ahead and looked at single-agent erlotinib in PS2, and again, pretty dismal outcome in unselected population. But that's not to say it doesn't have a role. In those who have mutations, there is a clear benefit. This was the Inoue study from Japan looking at PS2, 3, and 4. Remember, PS4 are bedridden, all having positive EGFR mutations. You see a response rate of 66%, and PFS and median survival. They're not too different from the good PS population. Helen talked about this earlier. I call this the Lazarus syndrome, where you're literally raising people from the dead or near dead. And it's important to check molecular markers in this population, with the notion being that you can really rescue such folks. We are currently now looking at afatinib in PS2 and 3 in mutation-positive patients prospectively. And finally, phase 3 study that looked at PEM-carbo versus pemetrexed alone in this population. We see, needless to say, more toxicity for the PEM-carbo combination, but in PS2, an improvement in response rate, in PFS, highly significant with a hazard ratio of 0.46, and overall survival in this Brazil-centric trial, 3.5 months overall. So survival benefit in PS2 regardless of the reason for PS2, whether it's the underlying cancer or comorbidities. And if we again go back to the French trial and look specifically at the PS2 population, we still see a potential survival benefit. So, In conclusion, PS2 patients are a sizable percentage of our practice, expanding number of PS2 trials, but unfortunately a relative paucity of evidence-based prospective data. In the proper patient, I will give a carbo-PEM or carbo-paclitaxel combo if they're non-squamous. Treatment practices obviously vary considerably, and prognosis regardless is worse in this group. We need better, more reliable, and reproducible scales for assessing PS. And combination chemo may have its greatest impact in this population, particularly in those who are symptomatic from the cancer as opposed to those who have comorbidities. And while the STELLAR trials were negative, I think they've at least enriched the literature with regard to prognosis. And targeted agents still have a role, but marker identification is absolutely critical. The empiric use of targeted agents, either alone or in combination with standard chemo, must be avoided. And finally, we need more studies in this group. And I'll end here with an exhortation to put your patients on clinical trials. I stop at nothing, even non-human subjects. So